I had a relatively minor procedure in hospital a few months ago, and I had a choice of, so I had private health insurance, which I could have used. If I went as a public patient in the hospital, there were no charges. If I used my health insurance, there was a $500 excess, and the same specialist charged another $260 above the rebate. So going as a public patient was free, and using my health insurance would have cost me $750. I was thinking, why am I paying $150 a month for health insurance, for example? And are they just loading? Even the hospital was encouraging me to go as a private patient, and I assume it's because they all will get more money, they will get a larger rebate. I thought all of these incentives are us about, and why would I continue to pay for insurance where it's more expensive to use it than it is to get treated publicly? And it looked to me to be much, in fact I've heard better reports from the public hospital than I have from the private hospital in the same area. So I'm thinking, yes, so my question is that how it seems?
Yeah, if it quacks like a duck and it looks like a duck, it's probably a duck. Basically, they charge more to private patients. In a sense that you'd got to the hospital, you'd got through some waiting list.
There wasn't one really much.
Well, if there's a waiting list, private goes in more quickly than public. Once you get in there, yes, if you don't tell the hospital that you are you have private health insurance, you get treated without cost. If you say that you have private health insurance, the hospital is pathetically grateful because they get a rebate from the private insurer. So that's why they want you to fess up, and that's why they ask you fairly aggressively when you get in there, have you got private health insurance? Of course, the private health insurer doesn't want to pay you, as Ian pointed out, with his fixed amount, with the above a certain amount you pay. So that, of course, means the fees naturally set higher than what the rebate was. So yes, you're exactly right. You pay more for being privately insured, and you were wise to shut up.
And the specialist charges more too.
Yes, he charges more and he makes more. Yes, he does.
So this is the sort of idea of, you know, when someone says, oh, how do
Come
you
to the microphone, please.
When somebody says, how do you determine how the cost of something, or the final price of something, and they say, oh, well, it's a cost plus some overhead, and it's no. The market's answer is the price is set by what the market will bear, and from the specialist point of view, he can charge more if I use private insurance, and they seem to be the wrong type of incentives, really.
Well, I think you hit the nail on the head there. Yes, quite.
Yeah. Okay.
Yeah.
Well, everybody, I'm sure, has heard the old saying, prevention is better than cure. When Don Chips started off the Democrats, he didn't have any power in Parliament, except for his own vote and one other. But he made up this policy. The Democrats were going to put the emphasis on prevention rather than cure. Now my question is that what is the chance of getting rid of the sickness industry and replacing it with a health industry?
Yeah, I mean, you're getting right back to the very design of government. And that is, and Arthur has really mentioned this about cost shifting. You know, if the workers' compensation insurer can shift it to the Medicare, that's great. There's a reward for that if the states can shift it. We've got a huge perverse set of incentives and boundaries which don't encourage people to look at health as a system. Now, John Menadue, and I'm going to give a bit of advocacy for what John Menadue says, he says, look, the health minister should be just as important in the government as the treasurer, should have a say in every policy, such as town planning. You know, do our cities encourage walking? They should have a say in sport. Are we blowing it on elite sports? Are we helping kids get fit? It should be about nutrition, diet. The health minister should have that broad input into all government policies. But one of the great tragedies, I'd say, in government in about 1986, government disappeared. The public service disappeared. And that's an extravagant statement, but what happened was, instead of there being people, particularly people coming into the public service, they didn't come into the public service. They came into the Department of Health or into the Department of Transport. This was all in the name of efficiency, and it wasn't particularly efficient, but it was about isolating each area of government. So one of the things I know that Tudor Hart is keen on, and you are too, is this notion of joined up government. So the government works so that all policies integrate. But no, for the last 30, 40 years, we've had what I'd call a very fragmented government, and that's particularly at the federal level, but also partly less so at the state level.
Thank you for your talks tonight. I actually found it quite enlightening. First questions were revolving around the idea of specialists having very high fees. To the second speaker, do you have any examples of how specialist fees have been able to be reduced through some sort of organised system or a policy that is actually universal but also quite effective in terms of keeping it down and also spreading the costs? Secondly, pre-1969 with the NEMA report, the system, I'm sure we sort of try to bring in a British kind of system and something that was actually universal for everyone. A lot of our politicians tend to sort of be usually ex-lawyers. They tend to be more in terms of pro-party ideology. But apparently in the 80s there was a system they were trying to introduce, I heard, about if you want to be a minister, say in medicine, you had to be a doctor. If you want to be a minister, say for transport, you have some sort of like, technical background. Would having ministers who actually had, say, medical backgrounds or specialisations in the area, all from that industry, would that actually help or hinder your the chance to sort of get a bit of balance and recorrection in terms of socially fair rather than private fair kind of business model or setup?
You do that first on the specialist.
It sounds bad, and it is. I don't really know what specialists charge. They keep the actual costs very much under wraps. I know what the specialists, neurosurgeons charge because the patients come back and tell me. It would be regarded as extremely discourteous if I rang them up and said, what do you charge for the first visit, mate, and what do you charge for subsequent visits? But I mean, there is a guy doing that and putting it up on a website, and so he should. There's very little cost control, and from my point of view, and I think all GPs, when they meet, they say, do you know any decent neurosurgeons, mate? I've got terribly long waiting lists. And the young blokes coming on have no publicity machine, so they might be quite good, but I wouldn't have heard of them, and then you wouldn't know what their track record was. I personally think that every surgeon who does every operation should go on a register, and there should be hard measures of how long were they in hospital and did they have a complication, and how were they 2 months later, 3 months later, whatever the outcome is, and they should be directly compared. And the young guys coming on should be there, and we should know who they are and what they can do and what their track records are and what they charge, although ideally, of course, they'd all be on salaries and they wouldn't. But it's very hard to know, and GPs say, oh, I've heard of this bloke. It's like saying, if I said to you, where's a good restaurant? You'd say, oh, mate, I know this one. Oh, it's terrific. So he's like, well, you know a good specialist, mate? Oh, that's very good, mate. You know, like it's at that sort of level, and not at any sort of systemic level, which is very bad. In terms of whether politicians should, so I don't know. So A, I say it's in a situation where nobody knows, and B, I don't think there's any mechanism that I know of that addresses this problem.
E.g. Singapore.
There is a thing called Rate MDs where patients give their doctors 1 to 5 stars, and the interesting feature I use of that is if someone is sent by an insurance company to a doctor, I look at his or her rating, and there's what I call the Dr. Jekyll and Dr. Hyde rating. Whereas if the patient goes to the doctor for treatment as a patient, he gets 5 stars. If he goes for an assessment by an insurance company, he gets told there's nothing wrong with him, and he gets 1 star. So he's Dr. Jekyll on his own patients, and Dr. Hyde when he's a lackey for the insurance companies, and they're the most dangerous ones. But that's the only rating system that I know, and I don't know of any system. In terms of your second question, which was, should all politicians only have portfolios in something they know something about? That's the question that Harvard, in the 1980s, Harvard said, no, you don't have to understand something to manage it, you just have to make good decisions. Well, how you make good decisions without any knowledge is you ask an expert, and then, of course, how do you judge who's an expert? Is it a credible-looking chap with a nice tie and a briefcase, or what? You know, if you don't know the subject. So my view is that Harvard management is simply an emperor with no clothes, but perhaps Ian might know a bit more at a systemic level.
Well, I'll start the specific on your territory. I suggest on your first question, go to Google Street View and have a look at the premises and what sort of vehicle is parked outside or in the driveway, and I think you'll get a fairly good idea. I mean, some of I don't know why. I don't know why the private insurers don't just hand this stuff, straight over to the BMW dealers. It would save transaction costs. On your second point, a lot of it comes down to who is advising the minister. Look, in a democracy, we're not necessarily going to get people well qualified. In fact, I think Woolridge was a medical practitioner, and I think he was the third worst health minister. He was pretty bad. In fact, as we've learned later, there are quite a few allegations. I don't know if they've been proven, but a lot of credible allegations of corruption. That in itself is not protection, but the protection is in the general government protection of a register of lobbyists, publication of the minister's diary, prohibitions on certain forms of campaign funding, transparency, accountability. It won't do everything, but it'll do a lot more than we have at present, because, and one of the things I didn't mention, but I have mentioned sometimes, we have a health department which has 3 or 4 big programs. They are hospitals, pharmaceuticals, ambulatory care or medical, and the 4th one is private health insurance. That is a crazy division. It's not a division according to patients or users. A division according to users, as Steve Duckett, who was for a time manager of the department, said, would say, okay, we've got people with chronic needs, we have people with occasional needs, there can be anything from an accident through to cancer, and we have the people with very occasional needs, which would be the occasional checkup and a flu jab. We should segregate the department according to patients, users. That's just normal business sense. But no, we've got this hospitals, pharmaceuticals, medical insurers. These are, it's a division which could not be more satisfactory for the rent seekers, for the people who are trying to sap money out of the system.
Thank you for your talk. Do you agree that universal, free, accessible healthcare should be a fundamental human right? That the Australian health system is being Americanised? There's a gross inequality and injustice where the public subsidises the private, not only in healthcare but in education and age retirement. What can we learn from other countries? The Scandinavian model, for instance, Cuba, far smaller economy, they provide a universal, free healthcare to their people. What can we learn from those countries?
Well, in answer to your first statement, do I believe in universal healthcare free at the point of delivery? Yes, that's exactly the essence of the main thing. In terms of a good comparison of different systems, I think we can use the American system as exactly what we don't want, and it's a very good system at turning sickness into money. If you see its objective as turning sickness into money, it's a world beater. If you want to turn sickness into recovery in a cost-effective manner, it's the worst in the world. You can't ride 2 horses at once. In terms of the best way to go, perhaps I should defer to Ian.
No, I'm going to be agnostic on that one. Yes, I could put a very strong case for free at the point of delivery. I could put a very strong case, as indeed the Scandinavians do, for saying that perhaps we should pay for something out of our own pocket, but a limited amount per year or per episode before the insurer kicks in. You know, that would be a universal public insurer. I can mount a case for both, but I think that should be the question put to Australian people in a mature political debate. You remember those? And saying, how do we want, how much should come out of our pockets, how much should we share? But not this sort of creeping privatisation. In fact, you know, remember just the last election, privatised Medicare. This was in relation to Dutton's proposal for a $7 GP payment. That wasn't about a $7 co-payment. That was about undermining Medicare so that it could go into private health insurance. And Labor got a lot of criticism for saying this is privatising Medicare. That was a false statement, but I don't blame Labor for having run that strong Mediscare campaign, because the government itself had not been open about what it was trying to do. And, you know, world of three-word grabs. Mediscare was a damn good campaign. But I'd like to see the whole rules change so that governments have to engage with people and say, look, here are your choices. Do you want a $1,000 tax cut and have to pay $1,500 more for healthcare through private insurance? If people make that choice, I think it'd be crazy, but if they make it, I think we've got to respect it. But that choice is not put to us. It's just stealth, policy by stealth, hoping that no one will notice.
I'd like for you to comment on what effect occupational health has in this country on the medical system, given that people are working longer and longer hours, getting more and more fatigued, particularly with a focus on the commercial road transport industry. Somebody before me made mention of preventative health, also with a focus on that comment too.
This is an area that I work in. It must be said that work cover in New South Wales has been totally castrated. There were 6 doctors and 26 hygienists working there. I think there's 3 or 4 hygienists left. They're replaced by people who tick boxes. As that has happened, there's effectively no inspectorate of industry, particularly in specialised areas, occupational health and occupational hygiene, which is dusts, noise, chemicals and so on. There's nobody who can measure these things adequately, even in the department left. There's a huge draining of public expertise. At the same time, there's been a huge change to labour hire. I have a patient who came in with the most terrible RSI I've seen since the 1980s. She can't do up her zipper in her jacket. She can't do up buttons. Every muscle in her body aches. She was working for Australian Hospitality Services, who subcontracted to one of the big hotel chains. And when she came in, some people don't believe in RSI and believes a sort of silly religious word, think it doesn't exist. Of course, it's a disease that had great trouble becoming established because it was work related, and there was an industry of insurers who didn't want it to exist, and the doctors were having trouble explaining it, and it wasn't in the books and so on. But those of us who worked on it and believe it exists in the sense that we've seen it often enough, think that it was an epidemic when computerisation came in and repetitive work came in the 1980s, and it's now coming on people who work too hard in repetitive jobs, and labour hire companies simply, if you can't come to work tomorrow, we'll get somebody else. So they're more or less become disposable people with no regulatory system, and the insurers simply lean on the doctors to say people are fit to go back to work when they're not. So yes, it's a big problem. I think I've done a little bit of work, not particularly professional in the truck driving industry. The ones that are on contracts for the bigger trucking companies are a bit better off. The ones that are individual operators are about 10%. They kind of take the overload because they're the load system. There's contracts where everybody, the big companies have most of the work and have routines and rosters. There's some hope of staying within levels of fatigue and distances and sleeping times. That gets overlooked for the individual operators, and they will fiddle their logbooks and so on, and I believe are quite dangerous and abuse drugs to stay alive. I've had a patient who came to me to get his licence renewed. He was sort of 39 going on 60. He looked terrible, and I thought, geez, I should probably knock this bloke back. What can I find to look back? He just looks so damn sick. And he said to me, he must have seen it on my face, he said, "If you knock me back, doctor, I'll kill you. I've got a $400,000 mortgage on my rig and I can't stop work." I didn't find anything wrong with him, so I passed him and thought, I wonder what had happened if I had found something wrong. And he was found, I don't know who diagnosed him, as having sleep apnea some 6 months later and was stopped driving by somebody else. So it's a big problem in truck drivers, and I don't think the regulatory mechanisms are there at all. So occupational health is a big thing, and of course the workers' comp system is trying to dump the problems on Medicare. They're refusing to treat them. They get their doctors to say there's nothing wrong with people, or that their injury wasn't caused by work, and therefore they won't pay for it, and that pushes it onto Medicare. And of course the specialists won't work for Medicare, so if you need specialist help, you've got a problem. And I don't know, I think it's part of the dismantling of the civilised world we thought we lived in response to economic pressures. That's what I think. But that's not an answer, I know. It's only a problem, but that's what I think.
Arthur, you responded in terms of hours of work. What about stress? Even if there aren't particular hours, what about anxiety? I might lose my job. I might not be able to pay my mortgage. I might lose my house. What are the health effects of that sort of anxiety?
Stress has always been very difficult for doctors. You can ask a lot of questions, and the psychologists do. There's a thing called DASS, which is probably the commonly used. DASS 42 is the one I use, which is depression, anxiety and stress index, which you answer a bunch of questions and get a rating. In terms of how sick stress makes you, the experiments quantifying that have always been very difficult. The idea of stress gave me a heart attack or what. It's very difficult to quantify these things, and if you can't quantify them, the people who want to say they don't exist rubbish them. And so I honestly don't know the answer. Stress, there's a questionnaires, and we diagnose workplace stress as generally the DSM, what's the number now? 6, is it? DSM, Diagnosis and Statistical Manual, which deals with psychiatric diagnoses, has a number of features which you tick off, and if you get a certain number of these features, you define that as generalised anxiety disorder due to work, and that is the diagnosis that gives you a reasonable chance of getting workers' compensation under the New South Wales Act. So people like me simply use that questionnaire and then diagnose it and then go into bat and hope that the guy's got a good lawyer. But that's the best I can say.
Yeah, that does not the study by Marmot and others find that the less control we have over our work, the less agency we have, the more illness we have.
Certainly that's true, and I won a fellowship in 1985 to study workplace absence. They called it absenteeism, I now call it workplace absence. And certainly my findings were, from reading a lot of stuff, that the more control people have over their situation, the better their morale and the better their attendance.
Arthur and Ian, I'm going to thank you very much for a great evening. We're actually running out of time and the chairman's gone home.
I'm the chairman, yeah.
So we're going to have to wind up. But I think the issues you just were talking about are really very fundamental, and it brought to my mind all the tensions about inequality in Australian society, because to some extent one of the drivers of inequality is the very system you're talking about. Surgeons getting enormously rich from charging high fees and abusing this system, patients, getting what they can, but dealing with an increasingly unequal society, which is itself creating health problems, as Marmot and Wilkinson and Pickett and others have documented. So I think, although this looks like a health issue, it really is a whole issue to do with socio-economic structure, political processes. It's classic politics in the pub, and it's a pity in a way we haven't got a bigger audience, but I think we're going to have to wind it up at this point.
That's right, we're only 4 minutes over time. Give us a break. It's only 8:04.
And we're supposed to finish at 7:30 actually.
That's
Thursday.
Yeah. Okay.
Anyway,
Thanks very much.
Thank you very much.
On behalf of the masses here.
On behalf of the masses.
A brilliant session.
I have to announce at the end, I'm told to announce, there'll be no meeting next week on August the 30th. The week after, on September the 6th, the topic is Australia's asylum seeker policy, a growing culture of cruelty, ? The speakers are Dr. Barry Fatterford, GP President of the Doctors for Refugees, and Samantha Castro, who's co-founder of Whistleblowers, Activists and Citizens Alliance. Many thanks for coming. I'm sorry we've gone over time.
Thank you.